All right. Are you able to see some CTs? Yes?
Yep.
Excellent. All right. So not last week. I don't think we had this last week, but the week before, I think David had shown a very nice case of this, and I just wanted to show a similar case, but with findings in a different location than his case. So I just want to pull up this patient's chest x-ray really quick, where we see these areas of sort of very kind of well demarcated density in the upper portions of the lungs. You'll notice that this patient has a vascular stent, possibly a venous stent here. I think we oftentimes see that sort of in this subclavian or axillary location in patients who have renal dysfunction and are on dialysis, and that's exactly what was going on with this patient. But just to show the CT correlate of those X-ray findings, what we see on CT are these very well demarcated areas of mostly central lobular, kind of ground glass, but like very high density ground glass nodules. And they persisted on multiple CTs and kind of didn't change at all. These two CTs that I'm showing are a month apart. And we can see those persistent, again, very well demarcated areas of central lobular dense nodules. And so in this patient with renal failure, this was also a manifestation of metastatic calcification, which I know Dave had shown really nice example of it in the soft tissues on a prior conference, but this is just an example of it appearing in the lungs as well.
Zowie.
Yeah.
It tends to be upper lung predominant.
Mm-hmm.
So I've had discussions with our pulmonologists, and they say that has to do with the pH gradients in the lung, because the upper parts of the lung are relatively basic, and the lower parts of the lung are relatively acidic because there's a higher concentration of carbon dioxide. This has to do with ventilation and perfusion, and I'm going to have to reflect on the mechanism again. I don't have it on the tip of my tongue, but this metastatic calcification is usually worse in the upper parts of the lung, as in your case.
Nice. Awesome. Thank you for that. All right, and then my other case is this one here. So this is a youngish patient, mid-40s, who is presenting with multiple of these areas of nodularity throughout the lungs. We can see several areas of sort of smaller micronodules. Many of them are clustered along the bronchovascular tree and these more sort of confluent areas of kind of nodular consolidation with little speckled micronodules around them, right? A nice kind of galaxy type sign in the lungs. And on mediastinal windows, we do see that there are some enlarged mediastinal lymph nodes kind of relatively symmetrically throughout the lungs. So this was, I think, a decent look for sarcoidosis, which is in fact what this patient has. But the reason that I am presenting this case is because they also have another very dramatic finding to go along with their sarcoid, which is here on our exhalational imaging, right? You'll notice up here at the apices as the patient exhales, this right upper lobe remains very loosened and actually kind of looks like it's pushing the mediastinum towards the left, which is normal, and sort of shrinking down as the patient exhales. And we see that even more dramatically here in the mid portions of the lungs with this really significant area of air trapping here, as well as multiple additional areas of air trapping in the left lung as well. And it's really almost the entirety of the right lung, which has air trapping in this case. But this is something that we can sometimes see in the setting of sarcoidosis. And I think, and please correct me if I'm wrong, the idea is that like some of these nodules are involving the airways themselves, or at least impinging on the airways themselves and leading to that really dramatic air trapping. So this is just the most dramatic example of air trapping I've ever seen in sarcoid.
Yeah,
Again,
that's impressive.
Zowie.
Yeah.
That's impressive.
That's beautiful.
Yeah.
Travis, have you seen that to that degree? I've never.
Not to that degree. No, you can, like Maya, like you're saying, I've read that too, where either granuloma is obstructing airways or a fibrosing mediastinitis-like effect from fibrosis.
hmm
That's,
Yeah. This patient didn't have, I mean, they maybe have a little bit, but not a ton of fibrosis at this point. So, anyways, those were my cases. Just nice examples of slightly unusual pathology or presentations.
Thank you.
Hi, David, it's been a while.
Yeah, indeed. Do you have something to show?
I do. Shrav, do you have anything, or Shrav? We can. I'm happy to show mine now. I'll go. Let's see. And let me know if do you see my database window here?
Yes.
All right. This one just came in a few days ago. And as Maya probably heard me say before, the best cases are the ones we're often correct, right? Those are the ones that we're right on. This is one where this patient came in, trauma, high speed, actually got T-boned with significant intrusion and didn't go straight to the CT scanner, as most traumas do. The trauma team saw this, and of course, you've got dilated viscus here. And the patient was very unstable. They saw this and said, diaphragm injury, looks like stomach up in the chest. Let's go to the operating room. Now, they are correct, but I pulled it up a few minutes later while anesthesia was getting ready. Anything else you see that you don't like? Anyone? And obviously, I'll give you the rib fractures, the pneumothorax.
That lucency over the mediastinum or to the right.
Yeah, I don't know if there's pneumothorax. It's not that. So,
Okay.
yeah,
There's a lot of tracheal deviation. Is that
yeah, there
because?
is.
Yeah.
Yeah,
So,
yeah, go ahead.
so it's possible if there really is a rupture of the diaphragm, we've got viscus up in the chest, that would allow the mediastinum to be pulled to the other side. But somehow it seems disproportionate. So I wonder if there's something in the mediastinal hematoma leaning on the trachea.
Right. And that's what I was worried about. I was worried about mediastinal hematoma here, especially because you don't really have a distinct arch, don't really see the left pulmonary artery. There's certainly no AP window here. And I think a lot of our trainees love to just throw a caliper or say, oh, the mediastinum is widened, but it's more than just like widening of the mediastinum, right? It's the hematoma that is obscuring your normal landmarks and, of course, exerting mass effect. So wasn't sure, but we gave him a call, talked to the anesthesiologist who relayed it to the surgeon. Let's see, this is post-repair of the diaphragm, and now you can see the things have shifted back, but still a little too much here. And here's the CT. So we don't have the diaphragm injury on CT, but on the non-con, and of course his arms are down his side, but a little bit of hematoma here, and he actually did have a traumatic aortic injury in addition to his diaphragmatic injury, which it's still he got T-boned at a high speed. He was the driver. There was an intrusion in the car, which explains all the rib fractures and the diaphragmatic injury. I usually think of rapid deceleration in patients that were going at a high speed, not somebody that just gets hit in the side at high speed, causing enough shear for a traumatic aortic injury, but that's what this was. The other thing that's interesting and curious too is it looks like he's got a little bit of a ductus diverticulum, or I mean, in theory, that could have even been a tiny little patent ductus arteriosus. But yeah, it's a combination of two pretty intense injuries here, and fortunately underwent successful endovascular repair after he had his diaphragm repaired. So
Impressive.
Yeah, just, I mean, and I wasn't, this is one of those ones where it's like, we've all seen cases, I think, where it's pretty high pretest probability on the radiograph, and oftentimes they've already gone to CT. And this one I was not sure. And I was thinking kind of like what David was saying, maybe the mediastinum was just pushed rightward from here, but it certainly was indistinct. And or could there have been a venous bleed or whatever, but it did turn out to be the aorta. All right, here's one I've never seen before. Let's see, I need to get the timing right. So let's make sure we're going in the right order here. Okay, so this guy, couple different surgeries, a couple different wedge resections, has underlying emphysema for a couple different lung cancers, ended up with an air leak. So this is, post-op day something. And then this is when he had been sent home with a chest tube or to rehab or somewhere, and still has an air leak. And it was at this time, well, I'll just pull up the next one and then I'll show you the difference, because here you can see this is the next day. He was seen in surgery clinic on this day, and then woke up the next morning and had a new chief complaint. And I will window so you can see. So here's his chest tube. And the next day, what do you think? There's his chest tube. And I'm glad I didn't see this, because I might not have recognized this, because I never thought about the fact that a chest tube might just totally slip into somebody's thorax and be disconnected from the rest of the world. But when he was at clinic the day before, the surgeon's note said that they shortened his chest tube in clinic, and then he woke up the next morning and couldn't find his chest tube.
Wow.
So it didn't. So it's not like it just sheared at the chest wall or anything, but it's just hanging out. And they did a CT because they can, and it just ends right there.
Wow.
So they did a VATS. They were able to get in there with the thoracoscopically and take it out. But
So what's the rationale for shortening a chest tube in the clinic? I mean, do people do that all the time? Do people just start whacking away at the outside part of a chest tube? I've not heard of that.
Yeah, I haven't spoken to the specific surgeon that did this. I have no idea. That's a good question, but if I'm reading this in the stacks and I say chest tube unchanged terminating near the apex with subcutaneous gas and maybe a tiny pneumo, no change, I'm not really doing a full account every day to make sure still the other side. So
maybe the patient wanted, found it to be kind of unwieldy or something.
yeah,
So
I know. I mean, right.
shorten.
Basically, it was like, yeah, he woke up and could not find his chest tube.
Oh my God.
So I mean, yeah, he had to go back to the OR, but so obviously it is a complication, but fortunately one that was correctable. All right, and this radiograph. This guy's young. I think he's in his 30s. This is not a diagnostic dilemma at this point. That he has whatever you want to call it, giant bullous emphysema, vanishing lung syndrome. And I will say it's not a diagnostic dilemma at this point. This is not a pneumothorax. Now, sometimes we struggle with these and you say, well, is there a pneumothorax? But I don't see a pleural line. And when you look on the CT, there's a couple little strands through this thing, it's got a little bit of wispiness to it. So it looks like it's just a big bulla, right? Of the giant bullous emphysema variety. Agreed. Does everybody agree?
Agree.
Agree with caution.
Yeah.
Yeah.
Sounds like a
Well,
leading
okay.
question.
Yeah.
Well, yeah, right. Okay, so here he comes back, and this is his return X-ray when he has new symptoms. And I don't know if I've ever actually seen a patient with bullous emphysema this bad that then ends up with what is a clear-cut pneumothorax.
Oh no.
Here's the white line, right?
Hmm.
There's the line. He's got an apical component. And this is still that huge bulla
Wow.
so it's basically a balloon, that didn't necessarily pop, it just popped somewhere else in that pleural space. So I have a CT of this too, and you'll see there's that humongous bulla taking up all that space because the catheter is anterior to that. Oh, I can get rid of this radiograph. And there's the pneumothorax separate from it. Now, they have some, and you can see he's got a staple line. He'd had prior, I don't know if they did a wedge or something years ago for a spontaneous pneumothorax. But yeah, I think this, if there was any doubt before, this conclusively shows that this isn't just an enormous bulla in this guy's right lung. But I just thought that these two radiographs side by side are very instructive. They've switched sides on me now, but just like as a good teaching point, looking for that white line with the pneumothorax.
The radiograph appearance of the bullous emphysema and pneumothorax, that has to have some sign name. And if it doesn't, maybe what do you
Name
think?
it.
You can have it.
Shrav is good at making up names. That must have been a really difficult line procedure to put in, not to end up in the bulla. They did a good job.
Yeah, that's a good point. And then there's the lateral too, but yeah. All right, and then the last case here, which again, best cases are the ones you're right on. We're going to start back in 2023. So 2023, this patient, he's had a remote left lower lobectomy 15 years ago. This is not a weird lung cancer recurrence. But he does have a history that turns out to be relevant at a time, and I'll show you. So he just has a lot of ground glass opacity. There are a few lobules that are less affected. And I just got involved with this case in the last month or so. And then he comes back, and I think this is read as still some ground glass, but not necessarily as dense as before. And I know if Jeff were on here, that he would make a comment about the presence of the intravenous contrast. And I think that's probably what's causing the difference in lung attenuation and a little bit of difference in lung volume. So basically, I don't think these lungs are any better. And well, in fact, based on what the actual diagnosis is, I know they don't just get better. Here, this one as well, it's a venous phase contrast, but still, this is over the course of a few years, and he's had a prior aortic valve replacement, but over the last couple of years, he's had worsening respiratory status. He's requiring 4 to 6 liters and getting much more symptomatic. We do, so Maya, you show the great dynamic expiratory. This is all just static and expiratory. We've started doing a little bit of the 4D stuff, but aren't doing it routinely. I do miss it because I think it's better. But anyway, so his lungs just keep looking like this. This is not edema. And so they did a bronch, and they just found some lymphocytes and nothing really suggestive of anything, and hit him with some steroids, which didn't do anything. And then I saw this PE study a few weeks ago, and it still looks about the same. And so then you start to say, well, it's not fibrosis, right? If it is, it's like diffuse, persistent, unchanged, non-fibrotic hypersensitivity pneumonitis, which I'm not crazy about. Maybe some of these areas. He doesn't have end-stage renal disease, so it's not like a crazy case of metastatic pulmonary calcification. There's no real. He is not a smoker. It's not DIP or like widespread smoking related interstitial lung disease. But this is where you have to, I had to dig deep on stuff that I've seen before and stuff I've shown here before. And I don't remember who showed the first case of it, but I know I've shown one case of it. And when I pulled out the diagnosis and the pulmonologist said why, and I was like, well, I've seen a case and it looks just like this. So the guy has a history of polycythemia vera, which has converted to myelofibrosis. So, any thoughts? And the answer is, and I'll pull up anybody, Shrav or
Like
Maya.
hematopoiesis in the lung or something. I don't know.
Yep. And
Wow.
yeah, and actually, and they did confirm because they went back and looked at the transbronchial biopsy, and I'll get to that in a moment. And I was sitting in the reading room, and I was like, I wonder if this could be another case of EMH, given the history. His white count was like 50 or 60,000 now with his myelofibrosis. The one thing I wasn't certain about was just that his bones aren't super dense. His spleen is big, but like usually with myelofibrosis, right, you replace the marrow space is replaced. But this, and you can see this PDF I've got right here. Do you guys see that? Or
Yep.
do you just see
Yeah,
my
yeah,
yeah.
Now we see the.
What
So
are the risk factors for this?
well, we'll get into it, but like the pulmonologist came in and he's like, well, what does it look like? And I was like, well, if I remember, it kind of looks like this. And I found this article in this very first case. I was like, yeah, just like that. Like this case looks identical. The one, and that at least got him thinking maybe that's what it was. And they went back, reviewed the path, and I put in, I think, the excerpt from the path. You know, this was from the cytopathology. You know, due to the concern, deeper H&E sections of the two biopsies were completed, and they found a bunch of myeloid precursors from their known myeloid neoplasm. So, yeah, and it's just kind of like soft infiltration, I guess, of the lungs here. And the other case, I actually had two other cases. I'm going to pull up the other one, and then we'll get back to your question because I actually don't know the answer. But this is a case I showed years ago, and this was a patient who had splenomegaly at that time, nothing really in the lungs, but they did have the more typical, like more dense bones. They had some, I think, actual paravertebral EMH, extramedullary hematopoiesis. And I think, and then this was what they looked like, you know, very similar, right? Maybe a little bit more septal thickening, this one, and tiny effusions, but this one went to surgical lung biopsy at some point and was also extramedullary hematopoiesis. You can see they've had a wedge. So it's like the, yeah, this guy was in his 60s, myelofibrosis, and you know, this patient, I think this is probably a Kirk Jones report, but there was a little bit of NSIP associated with the extramedullary hematopoiesis. David, I don't know if you showed the original case, but you know, it's
don't
like
think
one of
so.
those things that we have to keep in our back pocket for infiltrative stuff that doesn't go away in patients with the appropriate history of some sort of usually myelofibrosis, I think, in the cases I've seen.
I've not, I don't think it was me because, I've seen a lot of marrow problems here, but I don't think I've ever seen anything involving the lung like this. So this is extraordinary. It's really dramatic.
And so this, let's see, yeah, Shrav, to your case, I don't know. I actually haven't read through this article to see, but in terms of risk factors, I don't know. All I know is that I've seen a couple of cases in patients with myelofibrosis, and for whatever reason, you know, it starts getting into the lungs. In this case report, they actually talk about whole lung radiation, which they're talking about in this patient in addition to the chemo. I don't know. But this other one was a UCSF case, and I might be able to find some info if the two of you want to go back and dig it up.
Sure.
So
It's an old,
Travis,
yeah,
Travis, your other patient,
yeah,
not the current patient, but your other patient
yeah.
wasn't also P. vera that evolved into
No, I don't. Let's
myelofibrosis.
see. No, I think it was just leukocytosis, and they found myelofibrosis. And like, yeah, in his case, this patient did have a little bit of extra, like, oh, look at that. I bet they had renal extramedullary hematopoiesis too, in addition to a little bit of paravertebral stuff. This kind of looks
Like
David, this
Erdheim
looks
Chester.
more Erdheim Chester
Chester.
like.
Yeah,
Yeah.
right.
But I've seen, I know I saw at least one case of beta thalassemia that had like pararenal soft tissue that was presumed extramedullary hematopoiesis because they had all the other findings too. So I guess the only take home is the lung is a site where you can get extramedullary hematopoiesis. I guess that's my take home. And beyond that, Shrav, let me know when you figure out what the specific risk factors are.
Sure. Okay.
But yeah, just it's something to think about because yeah, in this other case, they did a transbronch, throwing steroids at the patient thinking it's like quote pneumonitis NOS, but obviously it wasn't. So okay, I will stop there.
Got
How
a
do
couple
I
of cases I can show if you.
if I can figure out how to stop? Yeah,
I think you. Oh,
I got it there.
let me see. How do I share this thing? Sorry, looking. Oh, here it is. Okay, share. We will share the window here. And you should be able to see two screens.
Yep.
Am I not? Oh, okay. Yeah, here. Okay, so our first case. Let's see, what did the patient present with here? So this study is from March 14th. Okay, so this patient, the provided history is concerned for pneumonia or vasculitis. So, take a look at the lungs. There's maybe some infection, some clustered central lobular nodules, ground glass, whatever. That's, that's fine. Then we take a look for vasculitis. We're looking for any wall thickening. We don't see any significant wall thickening. Aorta looks fine. Everything looks good. And then we come to this area. We see a little like amorphous something or the other here, and we keep going. And, sometimes we see little amorphous areas of enhancement or hypoenhancement within vessels. And the first thing that comes to mind, since it's amorphous and just not well defined, is like some contrast mixing artifact or something. And maybe there's some another consideration, some inflow from like a weird vascular connection. But typically we see those things when we are in an early arterial phase. But notice this is like a pretty delayed, like 70-second chest with contrast, venous delay. And we're seeing this weird amorphous thing. So that struck the person reading this as being a little odd. So Brett took a look at this and he thought, let's just make sure it's nothing scary. So then we take a look, we perform an arterial phase CT, and we just did prospective ECG gating so that we could get a better view of the aortic root where there's a lot of motion artifact to see if there's any, any dissection or anything, if this turns out to be a positive finding. And we don't see any abnormal vessels that feed into the aorta. No, if there was a vein or something and there's retrograde flow, we don't see dilated tortuous vein. We just see the normal intercostal arteries here. But now we see that this thing is a lot more discrete. So the thing that looked like this amorphous filling defect that looked like maybe just some contrast mixing or artifact now is something that is much more real. And it persists, right? So that is concerning. And we can take a look on some other series here. So let's go back to the initial CT and we can take a look at the descending thoracic aorta. You see kind of a somewhat streak-like area, and it looks like maybe it's attached to the aortic wall there. And this is the follow-up. I think we had, let's try to reconstruct this. So we go to our multiplanar reformat, and then so here you can see that this is a lot more discrete and it's attached to the wall here. So whatever this is, it looks like it's, why would it be amorphous first and then look more discrete. Well, that suggests that it's something that's moving. So this is a thoracic aortic mobile thrombus, so TAMT. And it's something that's very rare, but sometimes is encountered and important, especially on a venous phase. If you see weird, what looks like contrast mixing in any vessel or cardiac chamber, just be careful about that. And you want to give it a second look, maybe recommend a follow-up CT if you see that. So this is the patient on the follow-up CT. That was acquired a couple of days afterwards. I believe they started anticoagulation, and then you can see this is decreased in size a little bit. And then eventually patient gets a CT about a month later. And so here you can see that this thing is significantly decreased in size. So it just looks like a little web with maybe a fleck of thrombus along that web. So thoracic aortic mobile thrombus, kind of a weird case. Next case, whoops.
You
So
don't know if that
this-
person had any symptoms from distal
I-
occlusion or anything like that? Didn't have
No.
a cold leg or anything?
No, I don't think they had any embolic events or anything that I'm aware of. Yeah.
So Schraub, did you pull up there's an old echocardiography literature paper that was the first one. I think they called it the TAMT.
Yeah.
Did you see that paper
I
from
have not seen the
Laperche?
paper.
Yeah, it's Laperche is the last name, Laperche, and they have a nice diagram in there where these happen, because that's a pretty that's a less common location, deep or like more distally, because usually it's the undersurface of the arch.
Yeah.
Where most of them occur. And it was David years ago who talked about flow and about how that's where you have slower flow. I believe it was you, David, talking about that.
Yeah.
Yeah.
Yeah, we had another case over the weekend that was just that. It was definitely undersurface of the aortic arch, and that had been like slowly increasing over many years, and we've just been watching it.
Yeah, there's another one that we have here. I think there is some question as to whether this was thoracic aortic mobile thrombus. Whoops. I don't know if this person had a follow-up though. I think it was raised as a possibility, but we just nobody followed this up. And it doesn't look like a well-defined plaque or anything. It's just kind of
Yeah.
amorphous thing. And this is kind of we can take a look here. Right about here.
Yeah.
And
And Maya, the one thing too, because I actually was wondering if this case, based on the location, and that it was becoming more distinct, if it was going to be an intimal sarcoma of the aorta, because that's the one thing if they're growing and they're more sessile.
But why would it decrease in size?
Like yours.
Yeah,
I agree with you.
that
Yeah, I'm saying for the one that Maya
increasing.
was describing,
Yeah.
if it's growing, that's the other thing to think about.
Yeah.
And I know Seth used to see a lot of those, I think, at the AFIP.
Yeah, interesting. So the next case that I have here is sort of interesting. This patient came in, had probably had some shortness of breath. We see dilated right cardiac chambers, main pulmonary arteries dilated. So they have some pulmonary hypertension, and we see these filling defects. And so these are probably chronic emboli that are layering along the pulmonary artery walls. And then there was some question as to what this stuff here, this enhancing soft tissue along the right hilum, was. And so this patient underwent, I think, one bronchoscopic biopsy to interrogate what this to get a sample of this soft tissue, came back non-diagnostic, and then sometime later they underwent another bronchoscopic biopsy that just showed organizing thrombus. And so this just ended up being some some scar tissue and thrombus associated with chronic thromboembolic disease. And unfortunately, this patient went for thromboendarterectomy and then, due to massive hemoptysis, passed away. So I don't know, have you noticed or heard if having this sort of, is this stuff going to be really friable, and maybe that increases risk for massive hemoptysis, or And at some point, I know somebody had raised the possibility of like a fibrosing mediastinitis, but typically fibrosing mediastinitis, has soft tissue that is causing vascular stenosis, which is it doesn't quite fit the bill for that. And the reason the patient went to biopsy was to evaluate for neoplasm. But anyway, this is, I think, just all manifestation of CTEPH. But are there risk factors for patients who develop hemoptysis after thromboendarterectomy that anyone's heard of?
Can I back up and ask a more basic question? I've never heard of peri-pulmonary arterial inflammatory response to thrombus within the artery. You're saying that there was tissue outside the pulmonary artery that showed inflammation. Is that correct?
I think it just showed, I can pull up the pathology report here. Give me 1 sec and let's see what they said. So here's the second biopsy that was performed. And what did they say? So organizing fibrin, thrombus, right hilar pulmonary artery mass. Clinical history. See what they said. I think that is the main. Also did left hilar, and they found so all they found was organizing fibrin thrombus, and that's all they say.
I'm really worried about tumor here, guys.
Tumor?
Well, it's bilateral. Yeah, I was thinking more fibrosing mediastinitis. Scroll some more.
Yeah, I mean,
But
he
I
has
see what
like
you're saying.
calcified.
Yeah, David, I see what you're saying about how it's got that lumpy, bumpy internal.
Right.
Yeah.
Usually thrombus doesn't protrude like that.
Yeah,
This
but
looks like a firm mass.
Yeah.
And then
And
also, I mean, it's completely surrounding that
yeah.
bronchus intermedius. It looks fairly vascular out there. It's got all those little dots of looks like enhancement and stuff like that.
And Shroff, what did you say they did a thromboendarterectomy?
Yeah, pulmonary
Okay.
thromboendarterectomy, I believe.
But
Okay,
you said they did a hilar biopsy too, or mediastinal biopsy. Is that correct?
Yeah, by bronchoscopy, and eventually the patient underwent PTA.
yeah, I mean, if they did a full thromboendarterectomy, then they would have taken this out and seen that it was tumor. But
Yeah, I don't see the follow-up.
Huh.
I think it might have been referred out somewhere.
but David, I agree with you that I'm not used to seeing that peribronchial tissue. Now, certainly the hypertrophy bronchioles are no surprise in any of the conditions we listed.
Right. Yeah. So I had to forgive that part.
Do you think it could have just been a bronchial bleed? Like maybe some bronchial artery got lacerated or something?
I don't know. Hemoptysis occurs after a thromboendarterectomy. I've seen that before. Seth would be the one to probably weigh in the most from his time at UCSD.
Yeah. Yeah, it's a weird case. Anyway, I'll show the next case. So this is kind of an interesting case. Let's just leave it there. So here we can see that this patient has anomalous drainage of the right pulmonary veins into a scimitar vein that joins the infracardiac, the supradiaphragmatic portion of the IVC here. And we can see there's no right-sided pulmonary veins here. So this patient underwent repair of the scimitar vein, and the goal was to baffle the scimitar vein to the left atrium by means of the right atrium with an intracardiac baffle. So that was completed, and unfortunately the baffle went down. They weren't sure why exactly this happened, and the patient developed massive hemoptysis. And so here's all, a bunch of pulmonary hemorrhage everywhere, and the patient was not doing well. And since the the baffle had gone down. They knew they needed to go back in and repair this. And at the same time, when they opened up the chest to do the repair, they found basically the right lung was essentially dead. And so they go in and they decide that they need to resect, do a pneumonectomy because the entire lung is just kind of looking ischemic and, they don't want it to necrose and cause infection and other problems. So they do the lung resection, pneumonectomy, and here's the follow-up CT. So, patient has a little bit of thrombus. There's fluid in the pneumonectomy cavity. And does anybody else see anything that strikes them as weird?
The fact that it doesn't look like they did a pneumonectomy.
Yeah, yeah. So it looks like, they
It looks like
ligated,
airway. Yeah.
right. They ligated the right pulmonary artery, the intrapericardial portion of the pulmonary artery, and they pulled some lung out, and then all they saw was a big, what they thought was, hematoma in the right pleural cavity. And so they stick a sucker in there to get all of the blood out, evacuate it. They close up the patient, and then they scan them on CT. So we can see that part of the right lung has been left behind. They essentially pulled out the right upper lobe, and they ligated probably the truncus anterior, and they, they thought they did right pneumonectomy, but ended up only taking one lobe. And I don't know the details as to what went on in the OR or why they thought. I think it just didn't occur to them that maybe they left behind some lung, and so they closed the patient and took them back out. I think this is just, unfortunate, but it brings up a good, interesting learning point here, which is not present in this case. But if we go to the patient's pre-op CT, is that with patients who have scimitar veins, one thing that can happen is you can get some diaphragmatic tissue along the fissure that the vein sort of travels in here. So sometimes you can get slips of muscle from the diaphragm, like along this region. And one question was, is that why they got confused and thought that maybe they just saw a muscle or something? But I guess they were just worried about hematoma, and they thought that the entire remainder of the right lung was a hematoma rather than diaphragm or anything. But so when you see scimitar veins, make sure to look for thickening of the pulmonary fissures and, put it on soft tissue window to see if you see anything that is muscle attenuation along the fissure, because that would be something important for the surgeons to know about. There's like some case reports on that particular finding, but this was quite a remarkable case. They eventually did a completion pneumonectomy, and patient did well thereafter, but was kind of tenuous course in the, after the initial surgery. Has anybody seen anything like that before, or have you seen a case with that the finding of like diaphragmatic tissue along the fissure, or covering the right lower lobe?
That's been called an accessory hemidiaphragm.
Accessory hemidiaphragm, yeah.
Yeah, in scimitar, we've seen a few of those. I mean, nobody's ever proven what the tissue actually is, I don't think.
Yeah.
That's a lot of lung that got unintentionally left behind.
Yeah.
I mean,
It's
yeah,
surprising.
right. I mean,
Initially oh, go ahead.
I was just gonna say, I'm sure that, yeah, I don't fault the surgeons. Obviously, I'm not a surgeon, and I don't
Right.
have
I
any
mean,
idea how much of a mess,
right.
how complicated a case like that gets.
Yeah, I
But
mean,
wow,
there's going to be blood everywhere, and like, it's
yeah,
hard. But the interesting thing is, um, initially they were like, "Are you sure about this?" And the person who read the study was like, "Absolutely, yes. We can see like airways in here. We can
mhm,
see, air inside the airways and some vessels, and it looks like the pulmonary artery is just filled with clot because it's been ligated." And so for the fellows, I guess the teaching point is when you are seeing things that concern you, there's a reason that they concern you. Look for those features, like where's the normal anatomy, how is it distorted, And in some cases, maybe it's good to stick to your guns. Anyway, with that, let's go to the next case. So, I guess you don't see the chest radiograph here. I think. And then I think we see the chest radiograph now. That's not. Let's see. How do I pull this up? So a patient presents like this. So chest pain, shortness of breath, not doing well. Comes to the ER. And so, we see maybe hiatal hernia or something, and the patient has a pneumothorax. There's a pleural effusion, kind of consolidation here in the left upper lobe, and so they decide to get a CT. So here's this patient at this point was at some outside hospital, and so this is what we're seeing. We're seeing the pneumothorax, a little bit of thickening here along the pleura, but anyway, we see some consolidation here, ground glass opacities, interstitial thickening, some septal thickening, interlobular line thickening here, interstitial. And you come here and then you see this left upper lobe anterior segment artery. Why does it look so weird? And usually the artery is pointing this way, right? So it's kind of curving along with the mediastinum, but this one's flipped in the opposite direction. You come further down, and what happened to that left main bronchus? Well, let's take a look on the soft tissue series here. Sorry, give me one sec. So here we're seeing the left main bronchus. It just kind of peters out, and then we see a little bit air within the distal left main bronchus, or maybe at this point the lower lobe bronchus, and some secretions in the airways, but that looks a little bit truncated. And the other thing, if we scroll up here, we're able to see this structure that looks like it's tapering, right? So there's a tapering structure here that we can see better on the lung windows. And if we follow this tapering structure back to the left hilum, you can see it sort of follows the course of one of the pulmonary veins that goes to the left upper lobe. And so here's the left superior pulmonary vein. And we don't really see the rest of the left
Shrav, I
superior
don't see
pulmonary
anything.
vein.
Mine isn't scrolling anymore. I just see you stuck
Oh,
on a lung
sorry.
window.
Yeah.
Oh, thank you. Yeah, sorry. I pulled it up on a different window. So anyway, if you put it on soft tissue window, you track the vessel back down to the hilum, you can see that this is kind of coming from the left superior pulmonary vein, but here the left superior pulmonary vein appears like it's truncated, right? So all things to keep in mind. And I came across this case when I saw the follow-up CT, and the follow-up CT looked really odd. And so I went back to this, and one thing that was concerning to me was we have peripheral consolidation, central ground glass, and interstitial thickening, which is concerning for some sort of edema and, potentially this pattern you see with an infarct. And given that the left superior pulmonary vein is out, you think about pulmonary venous infarct. And also, we see that the bronchus is truncated. And so one thing that I was concerned about was a lobar torsion. Now, usually lobar torsions are seen after people undergo surgery, like some sort of lung resection. But this patient had absolutely no history of any intervention recently. And so this is a spontaneous pneumothorax. And if we take a look at the left base, we can see some rounded atelectasis. We can see pleural effusion with pleural thickening and enhancement. So there's, suggestion of a chronic pleural effusion and a spontaneous pneumothorax in this patient. And here I'll show you the follow-up CT. So by the time that I read the study, the left upper lobe was essentially dead. And you can see these weird distorted vessels. They're kind of, they're all distorted, and they have weird courses that you would not expect to see. And again, these vessels are not following the contour of the mediastinum, but flipped in the opposite direction. So this really concerned me for lobar torsion. And the clinical team actually didn't have any sort of diagnosis. This patient was just circling the drain. They didn't know why. And so I recommended that maybe, you should take the patient to the OR as soon as possible and get this torus lobe resected. Now, it's a really weird story, given that this is spontaneous, right? You wouldn't expect to see this in somebody who underwent spontaneous or who did not undergo any sort of thoracic intervention. So they take the patient to the OR, and the surgeon says that after the surgery, it was negative for any sort of lobar torsion, and that all they found was a bunch of pus in the left upper lobe. They drained the pus, and this is the postoperative CT. So they left the left upper lobe in there, and it got all necrotic, and eventually, unfortunately, the patient expired. Now, my question to you is, does that story of a spontaneous lobar torsion make sense? And the second question is, they claim that it was probably sepsis that led to the patient's demise. But of course, if you have a necrotic lobe that is serving as a nidus of infection that's not removed, of course, that's going to, lead to sepsis and death. One other thing I'll let you know is my sort of theory as to why this patient developed torsion. And in the setting of a chronic pleural effusion, I was kind of wondering, like, maybe the pleura looks a little bit more thickened than usual. So is it kind of like trapped lung and causing the morphology of the lobe to go from being sort of a pyramid to a ball? And when they developed some pneumothorax for whatever reason, did that allow more mobility of that lobe, leading to a torsion? And then as to the surgeon not finding a torsion, is that because it detorsed? Have you ever heard of that happening? Is that even possible?
Well, we've seen plenty of cases of spontaneous torsion. I actually had one within the last year from a pneumothorax on the right.
Okay.
There was one a UC case that Johannes Kratz ended up taking to the OR, where it was cancer. It was all adenocarcinoma in the left upper lobe that torsed the lung. And I know Jeff has shown a spontaneous one after a pneumothorax or pleural effusion. So that certainly can happen. And I'm sure David agrees that this looks like an edematous, what you would see with a torsed lobe.
Yeah.
Do you have a sagittal, or those look like
Yeah.
pretty thick sections? Because
I have a sagittal.
obviously seeing the airway, seeing the vessels twist in the
Do
hilum.
you want the lung or the soft tissue recon?
I don't know.
Well, okay.
Probably the soft
We'll
tissue.
start with what they've supplied us.
Yeah, we also had
So-
one recently within the last year at the VA that was a patient who had really bad like asymmetric pneumonitis from I want to say checkpoint inhibitor or something, but also had a big pleural effusion on that side, and so the lobe torsed within that effusion.
Are these all just thick slices? I mean, the issue is you need.
It's an outside CT.
Yeah, I know. Right. I mean, you really need a
I could
millimeter.
try-
So
Okay.
Travis, your case of torsion on the right was of the right upper lobe or what?
The spontaneous one. I mean,
Right.
no. The case I remember on the left that was spontaneous was left upper lobe in a patient where the entire left upper lobe was filled with adenocarcinoma, and I showed
Right.
that one years ago. The one on the right, I think it was just the run-of-the-mill spontaneous right middle lobe torsion, just from the long pedicle and complete fissures.
Mm-hmm. Okay.
So why my question, one question I had is, why would the surgeon have found no torsion? Like, have you seen cases where it kind of detorsed?
Well, I mean, it depends on what their definition of not torsed is
No.
and how they went in and did the surgery. I mean, I don't know. I wouldn't necessarily, what criteria are they using to say it wasn't torsed?
That's
I
true.
guess that's part of the question.
I'm not sure.
It sure looks torsed. And, I think once the surgeon goes in there, they deflate that side and stuff like that. There's a big pneumothorax, things can flop around into another position. So it's possible it untwisted. Then it's
I see.
possible that he just didn't recognize it.
Yeah.
That it was torsed because it was definitely not a normal upper lobe. So maybe all the features were just effaced. So
Yeah.
I wouldn't take that as gospel.
Yeah. Okay. That's all I have. Let me stop sharing. Thanks for the input.
What was last name again?